बंद करके वो
You can change your slides and check whether they are moving or not.
Just a minute.
Yeah, sure.
कैसे चलेंगे? They're not moving.
No, the slides are not moving. Now they are. Slightly they are moving.
Sound है? कोई का नहीं चल रहा.
Yes, they're moving now. So they're moving.
Okay, okay. Just a minute. Let me check this.
Yeah, sure.
ये कैसे चलनी है?
सर क्लिक करना स्क्रीन में.
किया था. इसको बोलने दे जैसे, है ना? नहीं फिर उसकी आवाज भी नहीं आएगी. Okay, are we done?
Yes, we are done with the settings, sir. We're about to go live. Just give us a minute. Once we go live, sir, I'll introduce you on the topic and then we'll hand over to you, sir.
Okay. वही लाइट बंद करना. पीछे पर्दा ओपन करो. करो और करो और करो.
So we are going to, shall we start?
Okay. नीचे करके लाइट ऑन. Yeah, okay.
All right. Thank you so much, sir. Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. Well, he is none other than the very renowned and eminent gastroenterologist, Dr. Raju Singh Chhina, sir. Sir is MD, GM, FAMS, MAMS, FIMSA, FAIMER, Director at the Department of Gastroenterology at Fortis Healthcare, Ludhiana. With Sir's enriching talk and with his wonderful insights and beautiful experience, we are going to talk about the topic for today's session, which is management of acute pancreatitis. Before moving on to today's session, let us have a brief look on what the topic says. In this session, we'll be learning about the managing acute pancreatitis, which involves swift medical intervention to alleviate symptoms and prevent complications. Treatment typically includes supportive care, pain management, and addressing underlying causes such as gallstones or alcohol abuse. In severe case, hospitalizations or specialized interventions may be necessary to ensure a favorable outcome. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Good afternoon, everybody. I'll be talking about management of acute pancreatitis. Pancreas is, as all of you know, an organ which is very vital to our survival. Before going into this, I have a short clip here which shows you, talks something about the pancreas. The pancreas Now, this was the data on pancreatitis, which once I was working at the Anand Medical College and Hospital, Ludhiana, we encountered. Alcohol was the primary etiological agent in the majority of the patients. Gallstones, especially CVD stones, were a problematic area. About 10% of the patients did not have a cause for it. Now, if we go into the pathophysiology, it is basically the interplay of various factors like CCK, alcohol, bile acids, which generates a cascade of events inside the cell, which leads on to cell necrosis, and this is the reason for pancreatitis. Now, we have the revised Atlanta classification for the definition of defining what pancreatitis is. It is diagnosed by the presence of any two of these followings: epigastric pain, serum amylase or lipase greater than 2 to 3 times the upper limit of normal, and third is characteristic radiological findings, a CT scan or a MRI or a transabdominal ultrasound. Any two of these leads on to a diagnosis of pancreatitis. Now, basically, acute pancreatitis would be divided into two types: interstitial pancreatitis and a necrotizing pancreatitis. The commonest is the interstitial pancreatitis, and the good thing about interstitial pancreatitis is that the recovery is much better. Mortality is only 3%, and generally the patients are able to survive. Whereas for necrotizing pancreatitis, which happens in 15 to 20% of the patients, the mortality is high, about 50%. Organ failure is very high. And if there is an infected necrosis, that means the necrotic tissue gets infected, then the mortality rises exponentially. We will now just go into the definitions of acute necrotizing pancreatitis. It is a severe pancreatitis where you have focal areas of non-enhancing pancreatic parenchyma on the CECT, and it has the phases, the first phase and the second phase. The phases are generally about 1 to 2 weeks, and it is the infections. The phases are: the first phase is the onset of symptoms, and the second phase is the area where you get infections. Now, necrotizing pancreatitis, like I said, two-phase disease: early phase less than 14 days, and late phase is more than 14 days, where you have the septic phase or you get into problems. Now, necrotizing pancreatitis, I told you pancreatitis, two types: interstitial pancreatitis, necrotizing pancreatitis. Necrotizing pancreatitis is also, it may be infected or it may be sterile. Two-thirds will be sterile and only one-third will be infected. And it is this one-third of infected area of pancreatitis which causes the problems. So again, coming back to the Atlanta classification, you have the type of pancreatitis with fluid collections. In interstitial and necrotizing, we can have a sterile fluid collection and a infected collection. The collection over 4 weeks is called a pseudocyst, and in necrotizing pancreatitis, collection over 4 weeks is called a walled-off pancreatic necrosis. This gets important because the management of pancreatitis is based on this classification. Now we will go over to, these are the scores which are used for assessing the severity of acute pancreatitis. There is no one score which is very good, but a bicep score, a SOFA score are there, and these are practically used for the management of pancreatitis. We even use the Apache scores, and various other scores are used, and basically it tells it about what is the degree of pancreatitis and what is the degree of severity vis-a-vis the outcome. Currently, no ideal predictor of severity is there. All prognostic factors and scoring systems show a good negative predictive value, but a low positive predictive value. Main value is to exclude a large number of patients with a low risk of mortality. So basically, that is the whole thing. Then you have a CT scores of pancreatitis severity. Now we come down to management of pancreatitis, acute pancreatitis. The simplest way to remember all the points is the word pancreas. If you see the slide, I have made it in red. Pancreas. So these first words denote the management of pancreatitis. The important thing is if you have a Ranson score of more than 3, or a BICEP score of more than 3, or a PASHA-2 score of more than 8, or patients with apparent organ failure, whether it's a renal failure, whether it's a respiratory failure, whether it's hypertension, cardiovascular failure, patients need to be in a ICU in a specialized center. Now we come over to the first point, that is P or perfusion. Now, hemoconcentration secondary to exudation of protein-rich intravascular fluid happens in the peritoneal cavity. So there is a large amount of fluid loss. So early fluid resuscitation, it leads on to a better outcome. Initially, there was a concept which was going on that you require a very large quantity of fluid and you require aggressive fluid management, which is getting slightly diffused now by a recent article in the New England Journal of Medicine, where they have shown very clearly that a moderate fluid resuscitation leads on to a better outcome. Moderate fluid resuscitation means infusion of 1.5 ml per kg per hour, preceded by a bolus of 10 ml per kg if the patient has hypovolemia. So earlier, we used to give very aggressive fluid resuscitation management, but nowadays, this is what should be followed. So this says infusion of 1.5 ml per kg per hour, preceded by a bolus of 10 ml per kg. And the fluid which should be given is a Ringer's lactate. And Ringer's lactate is generally the fluid which is helpful, much more better than 5% dextrose or normal saline. It is only if the calcium is very high or you are having pancreatitis due to hypercalcemia that you will not like to give Ringer's lactate, then you go over to normal saline. So these are the various factors they studied in the study, that the differences between necrotizing pancreatitis, persistent SIRS, ICU admissions, and they found that if you do a moderate fluid management, it is good. So what is moderate fluid management? 1.5 ml per kg preceded by a bolus of 10 ml per kg. So this is the ideal, but if you have any signs of fluid overload in the form of crepitations in the lung bases, or if the IVC shows a dilatation on a ultrasound, abdominal ultrasound in the ICU, then obviously the fluid has to be controlled accordingly. The second important thing is analgesia. So first we talked about P, perfusion. A is for analgesia. Analgesia can be patient controlled. We can give non-opioid. Opioid morphine can also be given, contrary to a generally held belief that we cannot give morphine. Now, the third part is nutrition. This is very important in the management of pancreatitis. And how do we do it? The nutritional supplementation is required. The concept of pancreatic rest is there. Total parenteral nutrition per se is expensive and generally not indicated in the management of acute pancreatitis. What we need to be doing is we need to manage pancreatitis role of nutrition with enteral nutrition. Now, there are various studies which have been done on the role of enteral nutrition, nasojejunal versus parenteral, and it has been found that nasojejunal has less side effects, less complications, and a better outcome than parenteral nutrition. So most of the centers across the world will not advise parenteral nutrition unless nasojejunal cannot be given due to a paralytic ileus or due to some other reason where we cannot give fluid through the Ryle's tube or through the nasojejunal field. The second thing is that, so if you see here, enteral nutrition has fewer deaths, operative interventions are less, systemic complications are less, multi-organ failure is less. So it is important that we give enteral nutrition. So the next thing is, how do we do the enteral nutrition? Do we go ahead with the nasogastric tube or we go ahead with the nasojejunal feed? There is a concept which people say that nasojejunal feeding is better, but we studied the outcomes in nasojejunal and nasogastric tube at our center, and we found that there was no significant statistical difference between the two study groups. But yes, if the patient is vomiting, having a recurrent vomiting, you are thinking the patient might aspirate, the patient is in a moribund condition in the ICU, then probably a nasojejunal feeding would score over a nasogastric feeding. The mortality in survivors was almost the same. The enteral nutrition, I already said, I'm repeating, has fewer deaths, fewer operative interventions, fewer systemic complications, and less of multi-organ failure. So enteral nutrition is the preferred thing. The third, so we talked about PAN, now talk about the clinical thing. Now, clinically, we have to assess the severity. And I told you that there are various parameters where you can assess the severity of pancreatitis. You have the various criteria. You have the Ranson's criteria, you have the biceps score, you have the SOFA score, and you have the Ranson scores. And if these scores are high, then the chances of severe acute pancreatitis is there. And why do we say severe acute pancreatitis? For simply, the reason is that the outcome is very bad with severe acute pancreatitis. And as these scores rise, the mortality also rises. One point which I need to stress is we should always monitor for the abdominal compartment syndrome, which means a sustained intra-abdominal pressure of more than 20 millimeters of mercury, because this is related to new onset organ failure. It is related to more of problems regarding the outcome. And the simplest way to measure it is using a Foley's catheter. Nowadays, we have better modalities also. We have apparatus which measures this intra-abdominal compartment syndrome pressures. And if it is available, we can do that. Now, important thing in clinical examination is you must suspect local complications as soon as possible, because the treatment outcome would be variable if the patient has local complications. The treatment outcome will be worse off if the patient has local complications. So we must always look for it. Now, these are few of the, how do you look for local complications? Now, procalcitonin predicts infection and organ failure, and PCT is one of the modalities which helps in predicting the morbidity, mortality, and infection in necrotizing pancreatitis. So this is widely available, procalcitonin levels, and they should be done in patients with pancreatitis to know what is happening. Now, the next is we have dealt with P, perfusion, A, analgesia, N, nutrition, C, clinical, what are the changes? Then what are the radiological signs and symptoms and how do you manage it? We can have the abdominal X-ray where you have a localized or generalized paralytic ileus, gastric dilatation. There are two signs, colon cutoff sign and sentinel loop, and they all indicate a sort of a paralytic ileus. On a chest X-ray, if you have pleural effusion of atelectasis, and this pleural effusion can be synchronous with ascites. And then on ultrasound, we look for the gallstones, we look for the CBD stones, and we look for ascites. And ascites generally is not a good sign in patients with pancreatitis. Then we can get a CT contrast enhanced, which will show necrosis. Necrosis, how is it looked up? IV contrast is given. Wherever there is microcirculation, it will be, the contrast will go. Wherever the microcirculation is disrupted in the pancreas due to a very severe attack of pancreatitis, the contrast will not show. So basically, we are able to pick up what is the amount of necrosis in a patient on a CT scan. Then EUS, endoscopic ultrasound, is becoming a very nice modality for checking for this, and also helps in the management of acute pancreatitis, especially fluid collections or pseudocyst drainage. Then MRCP is as good as CT for complications and necrosis. It picks up CBD stones. It has a better definition of solid material, and it differentiates between a pseudocyst and a walled off pancreatic necrosis. Now, when should we get a CT scan done? This is very important. If you are in doubt of the diagnosis, that means we talked about Atlanta, one of the threes, pain abdomen, MLS lipase high, and third was a CT oblique MRI or an ultrasound picture suggestive of pancreatitis, any two of them. If any two of them are present, there is no need to get a CT scan for diagnosis. A CT scan is generally done as a modality to look for complications, or if you are in doubt regarding the diagnosis, only then get a CT scan done. Now, radiology, we talked about. MRI, what are the advantages? It is reserved for detection of CBD stones, delineates ductal anatomy, lack of ionizing radiation. Pregnant patients, you cannot get a CT scan if you are in a problem. Then GFR less than 35 non-contrast MRI has a better resolution than the non-contrast CT scan. So CT, MRI, nothing much to choose, but in these areas which I have talked about, MRI is a little more helpful. Now, ERCP, as a gastroenterologist, we are very fond of doing ERCP. ERCP is indicated if there is cholangitis in the first 24 hours. If there is cholangitis, do a ERCP. How do you pick up cholangitis? If the counts are rising, LFT shows OTPT increasing or alkaline phosphatase or GGT increasing, or on an ultrasound, you see the common bile duct getting distended and you see stones there, then urgent ERCP is indicated. Generally, we avoid ERCP after 72 hours because of the simple reason that the outcomes are not so good, and it also becomes a little difficult to do ERCP because the whole of the duodenum gets swollen up and it is difficult to do that ERCP. Now, biliary interventions in acute pancreatitis, this is a whole lot of papers on it, and we basically do it if you have a continuous pain, a rising bilirubin, a dilating CBD, visible stone in CBD. And the important thing is you have to do it a little early. You cannot wait, and you should not be doing it after 1 week. Some people might not agree with this, but generally a patient who has been stable for a week's time, we can always wait a little bit and get the CBD stone out, unless the patient is going into organ failure or the cholangitis is becoming very problematic. The next area is antibiotics. Now, antibiotics, should you give, should you not give? The first protocol is antibiotics don't have any role in interstitial pancreatitis, which forms 80% of the group. So we should not be giving antibiotics if you are thinking that the patient has interstitial pancreatitis. If the patient has necrotizing pancreatitis, then I told you 2/3 will still be sterile, only 1/3 are going to be infected. So it is this 1/3 number, which is almost will become only about 5% of the total number of pancreatitis that you're dealing, who will require antibiotics. Now, which antibiotics? Antibiotics which have got a good penetration into the pancreas. Carbapenem, fluoroquinolones, metronidazoles, they can penetrate, cephalosporins can penetrate the pancreatic tissue, and we need to be giving them. But generally, total use of antibiotics is generally not good, and prophylactic antibiotics have no role in the management of pancreatitis. So if you are thinking of infected pancreatic necrosis in a necrotizing pancreatitis, only you do a FNA. FNA shows you gram stain is positive or a gram stain, gram positive or gram negative bacilli or a cocci are there. Then there is a point, or if the PCT is rising, or if the blood cultures are positive. So these are the 2-3 indications where you should be giving antibiotics. Routine prophylactic antibiotics are not recommended. They should preferably be based on a CT or a ultrasound guided FNA from the necrotic tissue. Now the next is surgery, oblique endoscopy, oblique intervention, what all is possible and what all we can do. Now, basically, interventions in the pancreatic necrosis, the first rule is we follow the Panthers trial, which is a very beautiful trial, which was shown, and they showed that you must have a step ladder management of acute pancreatitis. Don't rush for surgery. Delay the surgery as much as possible. So the first thing is do a conservative management. The second thing is do a catheter drainage with the help of an intervention radiologist. The third thing is you can go for an endoscopic drainage under ultrasound, endoscopic ultrasound or otherwise. And the fourth stage is minimally invasive surgery. And the fifth stage is open surgical necrosectomy. And it has to be done in this order. You cannot reverse it that the patient with acute pancreatitis comes, you think is very sick, and in the first week you take them for open surgical necrosectomy. It shouldn't be the last choice. Now, basically, when to intervene, this is very important because at times talking is easier than managing a patient in a hospital. But whenever you have an infected necrosis and in a symptomatic sterile necrosis, you have intractable pain or obstructive symptoms. So, obstructive symptoms and a high suspicion of infection. Now, infection should be documented, preferably with a fine needle aspiration. If it is not possible, then we go in according to the clinical status of the patient. Now, this was the Panther trial done in 2010. Basically, it had shown that the first stage would be you do a catheter drainage, second is minimal invasive necrosectomy, then an open necrosectomy, and you go in this manner. You go from below upwards, and the outcomes are much better. Now, how do you do an image guided drainage? The catheter is generally put in by an intervention radiologist, and it helps in the drainage of the necrosis, and you can even do a percutaneous necrosectomy with these techniques. The second is the endoscopic technique for drainage. The endoscopically, there are different techniques available. We have the endoscopic necrosectomy where insert a therapeutic gastroscope through the stomach and take out the this debris with either a snare or with a Dormia basket. The other things are that you can do a EUS guided drainage of the pancreatic collection. So this is the EUS guided drainage of the pancreatic collection with the insertion of a pigtail and a nasocatheter. This is a small video which I'll be playing with a needle knife. You make a cut. Okay. This is how you take a needle knife on the most prominent portion of the cyst. You make a cut, and as soon as you make a cut, you will realize that a lot of gush of fluid will come out. Then you push in a guide wire through this, and over the guide wire, this is the guide wire going in. You can see that yellowish thing guide wire. This is the fluid coming out already. So over the guide wire, then we dilate the path a little with a dilator or with a balloon dilator. It is a simple technique. You push in, dilate it, and then with a stent pusher, you push in. This is the dilatation. This is a balloon dilator. So what we are trying to do is we are dilating the path, and through this path, after you have removed this, you see the gush of fluid coming out. It is all pus-like material, and then you place a small stent, which may be a plastic stent. These days we have better techniques. We have the Axios stent, which can be placed. This is a video. I hope it plays. Can it play? Okay. There's a CT scan showing you a big video. So this is how Axios stent is placed. It is costly. It can lead on to some problems, the ears guided drainage. We have to be careful about perforation, bleeding, infection, and migration and recurrence of the problems, but they are taken care with proper management and proper pre-procedure protocols. This is few of the data we have. Now, there has been a shift in the management of pancreatitis. What is the shift? Earlier, failure of conservative therapies, the patients used to go into for surgical necrosectomy, antibiotics and delayed surgery. Now, what is happening is you do a step-up surgery. We do a percutaneous drainage necrosectomy. We come over to transluminal endoscopic drainage and transluminal endoscopic necrosectomy. Then we go to a surgical necrosectomy. So there has been a change from early surgical necrosectomy to delaying surgical necrosectomy as far as possible. Now, just to revise it, the important causes of pancreatitis: alcohol, gallstones, medications, post-ERCP, hypertriglyceridemia, idiopathic. Now, patients with biliary pancreatitis, no ERCP in the absence of cholangitis. Please do not do ERCP if cholangitis is not there. Cholecystectomy, if there is CBD stone, gallbladder stone, is done generally during the first admission after about 2 weeks. Use goal-directed fluid therapy. We should not be using too much aggressive therapy of fluids. And what is the goal-directed thing? 1.5 ml per kg after a bolus of 10 ml per kg. No prophylactic antibiotics. Prophylactic antibiotics have no role in the management of uh, pancreatitis. Initiate oral feeding instead of nil per oral. Oral feeding means either we go through a gastric tube or a nasojejunal tube, or if the patient can tolerate and we have a moderate pancreatitis, oral feeding should be this. The parenteral nutrition is generally not a good choice. Enteral nutrition is needed, and for patients with alcoholic pancreatitis, perform alcohol counseling during initial admission itself. Now, how do we go about this? If we see, these are the 10 points for management of patients with pancreatitis. Treatment on normal ward in case of mild pancreatitis, and re-evaluation on a daily basis to identify patients at risk of severe course. Mild pancreatitis can be easily managed. Consider ICU admission in case of organ failure. Then diagnostic workup, identify the etiology, confirm, exclude biliary etiology, hypertriglyceridemia, hypercalcemia. If there is hypercalcemia, do not use Ringer's lactate. Number 4, consider early CT scan in case of diagnostic uncertainty. If you are clear about the diagnosis, please do not get a CT scan. Only if you are thinking of infection and if you're thinking that 1 week or 2 weeks have passed, then a CT scan may be needed. Monitor intra-abdominal pressure in severe pancreatitis. This can lead on to a very good outcome, and this is one of the things which is generally not done in many centers, which should be done. Then correct hypovolemia and consider goal-directed fluid resuscitation, but avoid fluid overload. This is very important. Urgent ERCP only in case there is cholangitis. Oral feeding as soon as tolerated. Antibiotics only in case infection is there. And then 10th is considered drainage of infected necrosis, whether you go to an endoscopist, whether you go to a radiologist, whether you go to a surgeon. It is immaterial, but the important thing is the patient's condition should be managed. So concluding, ladies and gentlemen, a shift from early surgical necrosectomy to delay until liquefaction has become the global consensus for treating of infected necrotizing pancreatitis. There is light at the end of the road, as all gastroenterologist says. Thank you so much, ladies and gentlemen. Thank you.
Thank you so much, sir. Thank you for your enriching talk with such a beautiful presentation and the videos which you have shared with us to make us understand the topic better. Thank you so much for that. We have received a few questions from the participants, sir. With all your due permission, I would like to put across those questions.
Sure. Please go ahead. Please go.
Yeah. So the first question that we have received is, how do we educate patients and their families about lifestyle modifications and preventive measures to reduce the risk of recurrent acute pancreatitis episodes?
See, the important thing I told you about the etiology is alcohol is becoming a very important reason for acute pancreatitis, and the states which have a very high alcohol intake, like Kerala, Chandigarh, Punjab, and Maharashtra, the alcohol intake is actually increasing in these states, and the incidence of acute pancreatitis is also increasing. So educating the people on not to be taking alcohol on a regular basis, and binge drinking especially is a very risky thing. Some people go out on Saturdays and Sundays and they think that it is a free day. Thank God it's Friday, and they do a binge drinking. And binge drinking is one of the important reasons of getting an attack of acute pancreatitis. So educating the people about alcohol, then educating the people about symptoms. If you have a very severe pain which radiates to the back with vomiting, please consult a doctor, and if possible, get a serum amylase lipase if you have the etiological factors like alcohol or gallstones present there. So these are the few things which we need to be telling people on the prophylaxis point of view. Can we go to the next question?
Yeah, thank you so much, sir, for answering that question. We'll take up the next question that we have received. And the question is, how to differentiate between mild and severe acute pancreatitis, and kindly explain the key clinical and laboratory parameters used in this differentiation.
Okay, very nice. The important thing is you must know how to differentiate between mild and severe pancreatitis. I showed you many of the scores, but generally 80% of the patients will have a mild pancreatitis, and they do not require hospital admission, and they can be managed. Somehow, unfortunately, the serum amylase and lipase levels do not correlate with the severity of pancreatitis. What I'm trying to say is that if the serum amylase lipase are very high, that does not mean the patient has got a severe pancreatitis. But yes, if we do the scoring system, we do the Apache 2 scoring, SOFA scoring, bicep scoring, or the Ranson scoring. And if the scores are high, that indicates a severe pancreatitis. But one of the simplest ways to find out is any organ failure. How I put it across is any organ failure. If you have hypotension, if the patient has tachycardia, if the patient has respiratory failure, the respiratory rate is very high. If the patient has a serum creatinine which is high, these are all indicators of organ failures. And organ failure is generally an indication of severe pancreatitis. So this is how clinically you will make it up. But obviously, if you have the other parameters like a CT scan, ultrasound, amylase lipase, and PCT and a blood culture, if any of these is high, that indicates a severe acute pancreatitis. So mild pancreatitis, only pain, Generally, patient will get well, will not have any signs of organ failure, and generally can be managed easily, even as outdoor protocols. Yeah, we can go to the next question.
Yes, sir. Thank you for answering this question. We will take the next question up. And the next question is, what are the challenging or complex things that you have encountered?
Sorry, I could not hear
Yeah,
your
the question
voice.
regarding any challenging or complex case which you have encountered in your practice, and kindly if you can discuss the decision-making process and outcomes in managing that case.
Can you repeat the question, please?
Sure, sure. The question is, any challenge or complex case that you have encountered in your practice, and if you can kindly discuss the decision-making process and outcomes in managing that case.
There are a lot of patients of pancreatitis we have looked into, but we had a patient who had hyperparathyroidism, hypercalcemia, landed up with pancreatitis, did not really make the diagnosis in the first go of hyperparathyroidism, and then led on to certain problems. But every patient of acute pancreatitis, necrotizing pancreatitis, is a challenge in itself. No, none of the patients behave, all the patients do not behave in a similar manner. The important thing in management of acute pancreatitis is you have to keep your eyes and ears open. And I think 6 hourly determination of all the protocols, whether it is their vitals, whether it is their sensorium, whether it is their scores, at least at a 12-hour period should be done. And the outcomes would determine very largely to the outcome which the person in the ICU feels. If the ICU person feels that the patient is going downhill in spite of all antibiotics, in spite of the nasojejunal tube, in spite of all the fluid, then maybe the patient needs the intervention. And the timing of the intervention becomes very, very important. And what intervention also becomes very important. You must start with the easiest. The easiest interventions are radiological percutaneous drainage. The second one becomes endoscopic drainage. The third one is limited limited laparoscopic drainage. And the fourth one is open necrosectomy. But in spite of doing your best, sometimes you are not able to get through and you are not able to get good results. So the important thing in management of acute pancreatitis is that you must not always be complacent in your management and think that yes, the first attack has happened and the patient is going to get well, because recurrent attacks are known to happen even in the hospital. So we have to be very careful about managing these and keeping our eyes and ears open on account of this. Is that all?
Yes, thank you so much, sir. Thank you for answering that question. And one more last question, if you permit us, sir, then we would be taking it as we are receiving questions. So the last question that we are taking up is, what are the latest developments and research findings in the management of acute pancreatitis, including potential emerging treatment or therapies?
See, there is not anything which has radicalized the treatment of acute pancreatitis. There are certain drugs which people have tried. For example, we have tried unistatin in patients of acute pancreatitis, found it to be a little helpful. People have used certain drugs. People have used monitoring systems. People have seen the type of surgery which is there and the timing of surgery which they have tried to differentiate. But if you ask me for any one thing which has radically improved it, no, nothing much. But recent developments have been not too aggressive fluid therapy and a step-up approach to the management of pancreatitis, which is helpful.
Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And I would like to thank all the viewers for their ardent participation and for their keen interest that they have shown by staying tuned with us and putting us such interesting questions to us. And with this, I would also like to thank you, sir, for taking out your valuable time and for explaining the topic so well to us that we got so much of interesting questions from the audience. So this really means that they were actually attentive while listening to the talk. So thank you so much for engaging the participants as well, sir. Thank you for that.
Thank you. Thank you.
With this, we would like to conclude the session here for today. Until next time.